Good to see you. Yeah.
Stand up if you have five.
Howdy, Eggs. Thank y'all for joining us for Monday lunch. If you would stand, we've got prayer and pledge by Mr. John Kimbrough.
Pray with me, please. Loving Heavenly Father, thank you for all your blessings. We ask that you guide us and direct us, and Father, give us wisdom. Be with our leaders. May they lead our country in a godly manner. We ask you to be with Texas A&M. Guide us and direct us there too. And in your name we pray, amen. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. I, the Texas flag, I pledge allegiance to thee, Texas, one state, under God, one and indivisible.
Thank you, John. I don't have any silver taps to announce. If anybody knows of any, please let me know. Do we have any silver taps? All right. New members and guests. I see one back there. My brother's here today. Yeah. Aaron Richter, class of 2003. And what other class are you? He was in school for about 10 years. Most people in school that long are doctors. Mr. Dent will be able to tell us about that. All right, first I want to thank David Durkee over there with Circle G Catering. If y'all haven't tried that macaroni and cheese, go get you some. And then Aggie Women's Club in the back, for they've got pies and desserts. If you haven't got any, go back and get some. Aggie Athletics, man, what a game. The Aggies won. First football game of the season. A lot of players out, a lot of mistakes, but we're got to work through those, and hopefully good things to come this year. Also, we have an Aggie tennis update, Don?
No, the season's pretty much over. The men got beat in the SEC. I don't know about it. But I did have a little amount that I saw our good Aggie areas running for District 10. He said, make sure all the Aggies go out and vote.
Go out and vote. All right. On our capital campaign, we are getting close. We're down to 40,440 that we need left to get matched by Mays. And we are still planning on starting construction here coming up pretty quick. We've got the blood drive going on this afternoon. So for everybody that can stick around and donate blood, every person that gives blood saves 3 lives. There's also some shirts that are being given away if you're gonna donate blood. If we all take the orange shirts, we can pile them up afterwards and have a little Aggie bonfire. Barbecue's coming up this weekend, May 1st. So everybody come out, bring your family and kids, and gonna have a barbecue dinner, kids activities, live and silent auction, and complimentary bar for all those Aggies out there that like to have a good time. And we've got Coaches Night on May 19th. Jimbo's coming into town, and it's going to be out at Tejas Rodeo Outdoor Pavilion. So everybody get your tickets now.
Okay. Groundbreaking.
Yeah, there wasn't a slide for it. We've got a groundbreaking that we're going to do May 2nd. It's going to be the day after the barbecue. It's going to start at 2:00. And so everybody's welcome for that. And we'll have some refreshments and take some pictures out front. You do the shovel in the ground thing. So everybody come out for that, and we look forward to kicking off construction here in the next couple weeks. I hope everybody was able to watch muster online. Was there anybody that watched it online that was here? Hopefully it came through well. We have really good volunteers that helped us live stream that this year, and so that helped everything run a lot smoother. And I'd like to thank Reagan Freiling, Mark, Mary, the Aggie Muster staff, Aggie Muster committee. They did an unbelievable job, and it was good to have people back at the park. So if y'all could give a round of applause. And thanks for the Aggie Women's Club that provided the food and refreshments. Thank you very much. All right, Fiesta medals. We sold 2 today, guys. My brother
To
bought 2.
your brother.
He didn't get the discount. So if you buy 2021, get 20 for $5. He paid $20 for 2. That's all right. All right, member directory, still getting that put together. Don, did you want to say anything about that? Not at this time? All right, that'll be coming out later this year. And then a lot of merchandise has come in. If you'd like to take a look at these button downs, some of the different color polos that we have and hats, Mary's gonna have those over here at the table, so y'all can purchase them here at the park. And they'll be available at the barbecue as well. All right, I'd like to call up Reagan Frowling to talk about upcoming Monday lunches and introduce our speaker.
Howdy. Howdy. Okay, let me run through our list of speakers that are coming up. Next week, we have Philip de la Peña is going to talk about Cinco de Mayo. That will be the last Monday lunch here before we move our Monday lunches to Holy Spirit. So remember, if you show up on May the 10th, you might have to grab a shovel or work a caterpillar or something, because we're going to be over at Holy Spirit. We've got some maps over here, and our first speaker at Holy Spirit will be Greg Simmons. I talked to Greg yesterday, and he's going to come and give us an update. We've talked to Greg about helping us out with Coaches Night and doing some sort of live interview with Coach Fisher, and I think it'll be a good situation for us. May the 10th, that's May the 10th. May the 17th, we have Mindy Miller, K9s for Warriors. May the 24th, we've got the Dean of the A&M Law School, Robert Ade. June the 7th, we'll be off May the 31st. June the 7th, thank you, Dr. Mays. But we've got Major General Bruce Moore coming to speak with us, and I think that's going to be outstanding. The 16th of June, we've got Dr. Sean Gibbs, the Dean of the A&M School of Public Health. June the 21st, Jose Laguna with Lone Star Para Athletic Development Academy. David Gay, thank you for helping me line that up. And then also at the end of July, we will have the Dean of the A&M Med School, Amy Ware, that'll be here. So we've got some good ones on the horizon. So come back again, one more session here next week, and then we'll move it over to Holy Spirit. And the map, anybody have any questions about where Holy Spirit is, come and see me. Here's some of the pictures. It's kind of hard to see up here, but I'll have a map over here for you. Okay, today we're fortunate to have Dr. Daniel Dent, University Hospital trauma surgeon and professor. Dr. Dent completed his bachelor's degree in psychology from Duke University, and he obtained his medical degree at the University of South Florida. He subsequently completed his residency at the University of Tennessee in Memphis. His residency included an additional year of research in trauma and nutritional support. He joined the faculty at UT Health San Antonio in 1996, and he's received numerous teaching excellence awards. As a result of his commitment to surgical and medical education, he was named a distinguished teaching professor and was a recipient of the Presidential Award for Teaching Excellence. Dr. Dent's research focus is on trauma, autotransfusion, surgical infection, and surgical education. He is the program director for UT Health San Antonio Surgical Surgery Residency, and I believe he said he has about 66 residents under his watch. So I don't think he sleeps much. He is the past president of Association of Program Directors in Surgery and has served as a secretary and vice.
Thank you, Robert.
See if you can click anything on that.
There we are. All right. Well, thank you very much, and thank you, Reagan, for that kind introduction and for helping me get set up here today. So thank you, Becky, for inviting me, and being a good friend of our family for so many years. So I'm going to talk to you about our COVID-19 response. And the first part is going to be the region's response, and the second part is going to be our UT Health institutional response and what we did in the context of that regional response. And some of these slides were contributed by some of my peers and colleagues. This is not all mine. And for many of these things, I was just kind of a bystander and a passenger along a journey for this. Some of this was my work as well, but I want to acknowledge everybody that did the work and contributed slides and thoughts on some of this. So like I said, I'm going to talk about COVID-19 prevalence. I'm going to talk about our regional collaborative response, and then I'm going to talk about our UT Health San Antonio response. And within the context of that, I was asked to first give this talk to a leadership group. And so I'm going to point out some really interesting leadership paradigms that never would have occurred to me that we kind of went through as we've gone through this pandemic response. And talk about some of the creative thinking that's been necessary to handle this. So this is the COVID curves, and you know, we can, this cuts off a couple of months ago. We peaked back in February at about 1,500 inpatients. We were down to 1,100 at the time this slide was made. Numbers I saw today were down under 300 and starting to rise a little bit again. And I would argue this is the metric that we should care about. You know, you can see number of new COVID cases in a day. Whether they get hospitalized or not is unknown, just from that number. But when you start filling up hospitals, you change healthcare in a region. And that's what happened here for these two peaks. Now, we thought we had a peak back in April, so I'll refer to it as 3 peaks. But really, if you look at the numbers, we've had 2 peaks. I hope we're not going to have another one. We are starting to rise slowly, but we're still at a level that is okay. It is not really hurting our healthcare systems right now. But I do think inpatients is the most important metrics. It affects a whole lot of things. It affects access to procedures, screening colonoscopies, mammograms, things like that were not happening during these peaks. Your ERs fill up. When your ERs fill up, you can't get care for other things like your strokes, your heart attacks, your congestive heart failure, and those sorts of things. And as I go through our regional medical operations center, I'll tell you one of the things it does, I'm going to talk about it during COVID, but one of the things it does is when somebody shows up in Jerdenton or Pleasanton or Gonzales, Seguin Hospital, and they need health care that community can't provide, they start trying to transfer to one of the bigger, better facilities in San Antonio. And usually, 99+% of the time during normal operations, you can find a stroke center or a cardiac center or our trauma center or somebody that will accept that patient. And prior to the pandemic, on average, about once a month, there would be a hospital that would have tried and exhausted all the possibilities and they couldn't find somewhere to take the patient. They would send out a regional alert that we call a help call. And when you send out a regional alert for a help call, You get all the doctors in the area that run the different hospital systems and some administrators on a singular call within the next hour, and you figure out where that patient's gonna go. And a couple of my colleagues get on all those help calls, two people that contribute to this, Brian Eastridge and Ronnie Stewart, in addition to a number of other folks in the region. So we averaged about one help call per month for the last 10 years. During these COVID surges, we were seeing 10 help calls per day. Okay, patients with strokes out in Seguin and Uvalde that couldn't get to San Antonio to get stroke care. Patients with heart attacks down in Jourdanton and Pleasanton and Carrizo Springs and Dilley and couldn't get to San Antonio and get their care. And we were having 10 help calls per day, and some of them were ending with, "I'm sorry, we can't help you," which has never happened before. So the impact of the COVID patients on the other diseases is real and is not trivial by any means. So I'm going to try to focus mostly on COVID as I move forward. So the STRAC, that's the South Texas Regional Advisory Council, and it really was built as a trauma advisory council initially, but has expanded to include cardiac care, stroke care, behavioral health care, and other things. And this started being built back in the 1990s, and really was the brainstorm of Ronnie Stewart, my partner and chairman. It now, within the Texas healthcare system, there are 26 service areas, and our service area is Service Area P, which runs to Del Rio. In theory, does not include Laredo, but effectively does, because Laredo, if they get outstripped, San Antonio is the next closest place. So some of these areas don't really have a big city and big city hospitals in them. So we extend our coverage some, but in theory within Texas, we cover 26,000 square miles across 22 counties, which have 2.6 million people, 71 EMS agencies, 18 air medical bases, and a public health authority, 2 level 1 trauma centers, 63 hospitals. 16 of those hospitals are cardiac centers, 17 of them are stroke centers. And the 3 systems that really have to work together to give great care during any health crisis, whether it's the Sutherland Springs shooting or it's a COVID pandemic, you have to have an acute health system, you need public health as part of it, and you need emergency management, EMS, and pre-hospital providers. And the functional regional trauma system can provide a framework for an effective response to large-scale disasters. And we do education and we do drills on these things. We do citywide drills and what we do, it's actually interesting, we usually get the military enlistees that are going through basic training, and we can get a few hundred of them to pretend to be sick patients. They can be gunshot victims, they can be victims of chemical warfare, they can be victims of biologic warfare or whatever. And we can run drills across the city using school buses, transporting people all over the city to different health systems. But when the time actually comes, you need coordination around the city and you need communication around the city. And so that's where a regional medical operations center was envisioned. So we started our regional medical operations center back in 2003. It's now been functional for going on 18 years, and created formal agreements to ensure collaboration of all the major stakeholders, and created redundant communication systems and software systems so that in times of crisis, things will still work. And this is a picture of it right here. The first one actually really got operationalized was after Hurricane Rita. So after Katrina, the following year, Rita hit the Texas coast, and hospitals in Houston were calling with, we have 50 patients we need to transport, okay? And the system prior to that was set up for 1 patient at a time. Okay, I've got a patient who's hospitalized with congestive heart failure who needs to get to San Antonio. Well, because of the RMOC, we can now take calls of Methodist Hospital in Houston needs to send 50 patients. And we can sit in the middle of a room like this. It actually was built in our UT library, our med school's library. They cleared out a whole bunch of space and built up an RMOC there on about 6 hours notice. And were able to take phone calls from hospitals in Houston, and then they would go around the room and say, Mr. John, I know you're here, by the way. Mr. John, we've got 50 patients that need to come. And you'd say, well, Methodist can handle 18 of them. And then we'd go to Christus, and they'd say, well, we can handle 7. And they'd go to Baptist, we can handle 11. University, we can handle 12. And we would get all 50. And then we'd start arranging transportation with the military, providing mass troop, large helicopters, and things like that. And it was something that's never been done before. So we did that, we published it, we wrote about it, we became the envy of every healthcare system in the United States, and every regional healthcare system in the United States. So through that, we developed a regional consciousness. We developed the ability to expand bed capacity, because when you run out of beds, then all the hospitals can say, well, we're all out of beds, which means almost by definition, we all have beds, because you can't shut off ambulances to your hospital if there's not another hospital down the street that can have them come into theirs. So when everybody's closed, everybody's open. Okay, seems contradictory, but when everybody's closed, everybody's open. And so we then had to create group and regional areas to increase beds. But by distributing it across the facilities, the phrase many hands makes light work really came to be true. So we've load balanced and been able to do this with previous healthcare crises. So specifically during the COVID-19 pandemic, and I'm back to the same slides, these data obviously didn't exist. So we had to create a data system. We had to track COVID patients and the number of COVID patients in the hospitals. And you can see we started the data system back at the start of the pandemic. And one thing we didn't know was, well, how many patients are being admitted on a given day? So they added that to the data last summer. And now we know each day how many new admissions there are, because obviously the number of total patients is new admissions minus discharges. And some of those discharges are deaths, some of those are patients who recover and go home. But without being able to track new admissions and get an idea of what's going on there, the data wasn't as complete as it could be. So here's the data in San Antonio healthcare systems, ICU patients in purple, non-ICU but admitted patients in green. Here's the data outside Bexar County, but in our region. So we got all the other healthcare systems to contribute to the data set, and we can track the data across the region. Their numbers are lower. They tend to have smaller healthcare facilities. And here's an example. There were a number of examples, but this is one that I had a good slide for. When El Paso got hit, and we were past our surge, or actually between surges, El Paso needed to transfer patients out of their region because they had no capacity. So we worked actually statewide, and this communication system, which has grown, now allowed for load sharing across the state depending on capacity and availability. And this is a really great example of 179 patients that got transferred around the state to where there was ability to take care of them properly. So we now believe that the Regional Medical Operations Center really conveys a critical advantage in disaster planning and pandemic response, and it's a key component of our regional emergency healthcare system. We've been able to have the communication which allows us to coordinate things across regional boundaries, and we've been able to link the state to federal government and things like that in a tenable way. And I'll tell you, when I saw this happen the first time, I had kind of a naive thought about it. I wasn't born in Texas, but like many, I got here as fast as I could. And I'm proud of the fact that I'm a Texan. And what I saw between Katrina and Rita was, in Louisiana, I saw a state that kind of sat around and waited for the government to come in and help them solve their problems. And in Texas, I kind of saw a state that said, if we just keep the federal government out of this, we'll be okay. What coordinating with the federal government does, it allows for long-term sustainability of much of what you do. it allows for the funding of the things you've done kind of on a promise of, we'll be able to pay for this down the road. And so what we've done through our RMOC is to coordinate things with the federal government and work in an integrated way. And that really is the way all these things work best, is being integrated. So now I'll shift gears a little bit and talk about our UT Health San Antonio response. And back in our first surge back in April, when we expected a surge that we got a few patients, but it wasn't that many. Really a big part of it was acquisition of protective equipment, because there wasn't enough to go around. That's what led to some of the mandates at that time. It wasn't that people thought masks were a bad idea, but when the first guidelines came out and said don't mask, it was mainly because if everybody masks, the people that really need masks won't have them. And so that was the purpose of it. It was about basically rationing the availability of masks. Now that we have plenty of PPE, in both of our surges, we had plenty of PPE when we got the actual surges. That wasn't a problem. The other thing we did was we went around the hospital and tried to figure out, when these patients come, where are we going to put them? And so we went around the hospital and looked for space. We also asked, well, who's going to care for them? Because COVID is a medical disease. It's not a surgical disease. But there are certain limits to the number of adult medicine doctors we've got. And so when we outstrip them, and we outstrip the nurses in our medical ICU, and we outstrip the respiratory therapists in our medical ICU, what next? Who else is going to be involved? And fortunately, like I said, we didn't get a big surge in April, so we learned a lot of lessons from New York City. They went through a lot of growth pains, and some of them got it better than others by trial and error, but we were able to learn a fair amount from them. And then how do we train these people to provide care? Because if you're not a day in and day out medical, so Liz Scherer, one of our young trauma faculty in trauma and critical care, and had some very different, very innovative thinking about it. And she looked at the PPE acquisition issue. She helped with the space. Okay, we can mobilize nurses. We can mobilize doctors. Our rate limiting step here is respiratory therapists, and we're going to be short on those. So we need to train all the doctors and nurses in the patient's room. They need to look at the ventilator. There's water traps for the condensation that into our training. And so that became part of our training. The other thing she realized was that if we do that, our PPE will go longer. Because if a nurse or a doctor can do some of the things, that's one change of gowns and gloves, not 2 or 3. And so we'll actually make our PPE last longer. So she had some very forward thinking that out of the box, it had never occurred to me or most of the rest of us, and we employed that. And we put it into our training. And so what she came to is, with proper training, we can minimize the use of personal protective equipment and have physicians, our pulmonology critical care fellows, and I and Phil Luber, our chair of our medical education department, we put together a website with just-in-time training for doctors who don't regularly take care of adults with respiratory when a patient does X, Y, or Z. I know what diagnostic studies to order when a patient does this or that or the other thing. And so we put together an online training platform that our providers are on in a regular hospital bed. In terms of hospital beds, Liz Scherer, again pictured here, Lily Liao, who's our director of pediatric trauma, and Mike Russos, our hospital administrator. The things they had, we're going to get rid of some of these patients. We're going to have to make them ventilator capable. We're going to have to make them negative pressure flow capable. We're going to have to do all the things we need to do to make these COVID ICU beds, which is a whole other level of beds compared to many. And they did it in spaces that were not originally designed to be ICU beds. We'll leave the entire breadth of medical critical care. We'll get good at one disease. We'll become COVID doctors, and we can help them out with that. So we were going to handle up to 72 COVID ICU patients. And then we were going to fill up our recovery rooms and each operating room with more patients, and this would be a combined unit depending on whoever's available, including anesthesia critical care, surgical critical care, pulmonary critical care. Well, many of you probably heard the quote, "A plan is nothing, planning is everything," and that proved to be true during this pandemic. Because we had a plan, but it turns out 40 was not the right number for the medicine ICU, because these COVID patients are so labor intensive that once they started filling up with COVID patients, 40 was more than they could handle. So we had to cut back to 30, and we had to change our numbers and revise our plan. But because we had built an initial plan, we had a planning process and a planning group that met regularly, the ongoing planning continued, and that's what made the care possible. Tiffany Bergen, one of our professors in physician assistant studies, she realized that one of the hard things about these COVID patients is you've got to get in their room and flip them over from time to time. You have to prone them on a ventilator, which is no easy task when they've got a breathing tube down their throat, to get them and get in the room, not catch COVID yourself, flip them over and get out, and then 18 to 24 hours later, come back and flip them again and keep that process going to try to keep them with adequate oxygen levels. And at a time when students were being marginalized and not being allowed to care for some of these patients because of the risk of getting COVID, I say we fully understand it now. She realized she had a lot of her physician's assistant students sitting around doing nothing, and she said, well, let's figure out how they can help. So we created PA student learning teams, and they were available from 6 a.m. to midnight. And proning is never an emergency, so we didn't have to have them there all night long. We come around the units at 11 p.m. and say, does anybody need to be prone? And if they hadn't been proned already, or does anybody need to be come in, and they would wrap the patient up like a taco. They'd put sheets on top, sheets on bottom, roll them both, and then just grab them and flip them. And then unroll them and get the sheets out of the way. And literally they could be in and out of the room in about 3 minutes. Once they got the process down, they were outstanding. And they were a real help to us, because if you can imagine the standard doctors and nurses that are there, well, these patients are one nurse per patient, okay? And you've got a doctor that can help and a nurse, and maybe you can pull a nurse from the other patient, except he's now crashing. And so mobilizing enough people to do it is a real challenge with your baseline manpower. And so these folks were really helpful. And then Jennifer Lacoste from our geriatrics and palliative medicine team created a palliative team, because these patients, particularly the ones dying, were elderly, and real discussions need to be had about end-of-life care. And there were a lot of deaths, obviously, from it. And so we put a palliative medicine team on every COVID ward so that they could facilitate these discussions and make them possible, so that we could do the right thing by these patients. And we were able to mobilize some residents to help during the week. During the weekends, we got faculty, UT Health faculty from every specialty, volunteering to come spend the weekends making the phone calls. The patients' families can't be there, so you're doing this by phone or by iPhone, and they would make the phone calls and talk to them and translate them so they could make proper decisions of medical ease for the families to understand, so they could make proper decisions about their loved ones. Scott Jones is our leader for graduate medical education. He's a former military education leader, he's a pediatrician, but out of the Air Force. And he and I put together a systemic deployment of residents and fellows based on need and abilities. And there were, I don't know, half a dozen of us, but there were probably 3 of us that kind of took the lead on this. And the first thing we did was categorize what our residents and fellows can do from over 50 training programs in terms of what procedures they can do, what care they can provide for these patients. And we put together a spreadsheet, and this is small for a reason, but if you can imagine, the left column is individual names. These columns on the right are procedures and skills and knowledge of care you can provide. And red means you can't do it without a lot of supervision. Yellow means you can do it with some peripheral supervision. And green means you're comfortable doing it without any supervision, although none of our residents or trainees were unsupervised, but it just gave us an idea of what their skill set is. And at the top are our plastic surgery fellows who are fully trained general surgeons. All the red ones are our first and second year residents. And below where there's no red and there's yellow transitioning to green these are my surgery residents. The third year residents, and then my fourth and fifth year surgery residents. So they're all green, because if you think about it, a medicine residency is 3 years long. So when you're a fourth year surgery resident, you've already trained as long as medicine faculty doctors. And so they were signed off and checked out on many of the things we needed to do at the bedside. So we created this spreadsheet so that then we could have initially 3 times a week meetings about how are we staffing the newly built teams that never before existed all over the hospital. Additional inpatient non-ICU teams, additional inpatient ICU teams, teams at the VA, teams at the University Hospital, teams in the ER, okay? And we had to get together 3 times a week for an hour and figure out who's staffing these teams, who's gonna be where at the faculty level, at the resident and fellow level. And it required a lot of communication, but through these spreadsheets, we built up these teams and got them all staffed. So 3 people through this crisis taught me a lot, and they're listed here. Jason Kempenick is my associate program director that helps me run the residency program. Ronnie Stewart and Scott Jones I've already mentioned. The key was communicate, communicate, and communicate. You cannot over-communicate, especially during a crisis. But there's a cost to communication. This is my personal cost. For the 3 on the previous slide, they did more than I did. So some people put in 10 to 15 hours a week of additional meetings in their life to communicate with each other. We had to communicate with the faculty healthcare plan. We had to communicate with hospital leadership. We had to communicate with every residency director on campus. We had to communicate with our fellowship director. We had to communicate with the different teams and the departments that staff them. So my personal cost was, and there were phone calls outside of these because you wanted to be ready for the meeting. So you put in an hour or 2 of phone calls outside of these meetings so you'd have answers when these meetings came up. So minimum 7 hours a week added to my life in addition to the additional care we're providing to these patients. So this was not an easy task, but it was one we had to do. So the communication is important, but it requires some effort. So another thing we did, Mike Russos, our hospital administrator, recognized that bringing in outside doctors might help and outside nurses and outside respiratory therapists might help some of us in the system keep going with some of our regular day-to-day operations where we provide care to the patients of Bexar County for things other than COVID. So after the first big surge, in anticipating a second winter surge, we made arrangements to hire locum tenens people. And it's actually, we made arrangements to hire locum tenens people. And it's actually, these people are out there now, they're like storm chasers. They're like the tornado chasers. They're chasing COVID all over the country. And like, well, I was in New York and then I went to LA and now I'm here in Santa Ana. Great job at doing that. But we staffed 1 unit with locum tenens folks during the most recent surge. We're still looking at our outcomes across the region. But as near as we can tell, our outcomes are as good as anybody in the country. In terms of getting involved on the forefront of this, University Hospital was the #1 enroller of remdesivir in the remdesivir trial worldwide. Our infectious disease doctors have been very involved in this. I didn't mention any of them by name, but they've done a great job. We deployed in the first surge, we're still looking at data from the second one, but last summer's into the fall surge, we deployed 193 residents and fellows to provide COVID care. And we surveyed them afterwards and asked, how did this go and how could we do better for the next time? And we made changes based on their responses. 2/3 of them said it was a positive experience, and over 90% of them said they were well trained and well protected with good PPE and good supervision. And so we considered that a success, but not perfection. and we looked at some of the things they gave us in feedback on how to do better, and I think our survey results for the second surge are gonna be better. We're currently load sharing in terms of vaccinations, and this is a very rapidly moving target, so this slide is not that up to date. They opened at least one new clinic today down on the south side, so we're starting to spread out around the city to get to people that maybe can't get to the Alamo Dome or some of the other big vaccination sites. And we are among the leaders. If you look at San Antonio's numbers in terms of vaccination, we are, last time I saw, #1 distributor per capita of vaccines in the state of Texas. So that's the end of my COVID comments. I'm gonna put in a shameless plug to remind you of what you were already told about, that there's a opportunity to donate blood today. There's a blood drive going on. And then also I've been asked to mention, if you can, this Saturday, we're doing the cookout. And if you can purchase extra meals to go to first responders or healthcare providers, we're going to be delivering a bunch of those just like we did last time. And I know our nursing staff at University Hospital are looking forward to it. They've been made aware that it's going to happen this Saturday. So the more we can contribute, the more we can donate, the better. So with that, I'll stop talking and I welcome questions and comments. And if someone wants to get the lights, awesome. Thank you. So thank you very much.
Did each hospital system go through this same process, like Baptist and Methodist?
So, Mr. John, I believe the answer is yes, except they don't have as many residents or fellows. So they did it with their private practice physicians. And they had people practice that. I hate to use the phrase practicing outside their specialty, but they had people have to train up to practice in areas that they're not all that familiar with. And there was hiring of nurses from other places and paying a lot of overtime and that sort of thing. So their approach was slightly different, but the short answer is yes. Yes, sir.
Okay, I've been wearing this mask for over a year now. How much longer am I gonna have to wear it?
That's a great question. I'll give you my opinion, okay? First thing I want to say is you can't be both pro-economy and anti-mask, okay? This mask is the key to the economy. It's the economy's best friend. Because while there have been businesses shut down because of legislative policies or other mandates, I've also been to half a dozen businesses that I tried to give business to that I couldn't because they were shut down because all their employees had COVID. So COVID will shut down businesses just as fast as legislators will shut down businesses. My personal thought is we're still looking at what is herd immunity with this disease. It's somewhere between 75 and 90%. And once we figure out that number, when we get to that, plus a 2% testing positivity rate, I think it'd be reasonable to say you don't have to mask if you're vaccinated or if you've had the disease, okay? If you're neither vaccinated nor have you had the disease, you probably should wear a mask. Is that, and I wanna ask, I welcome input because it's a moving target and that's just my opinion. Do you guys think that's a reasonable answer? I guess is the question.
Follow-up question would be, where do you think we are compared to where we were 6 months ago?
Yeah.
I mean, is it going to be a significant basis? Is it still necessary? I mean, you got customers that are arguing this.
Right, so I think it's a mixed, like many things about this disease, it's not an easy answer. It's a mixed thing, and here's why. If I remember the numbers right, we're about 30% are fully vaccinated. Another 20% have received one dose. So we're up to about 50-ish% have received at least one dose. What we don't know is of the 50% that have not received a dose, how many of them have had the disease and have some component of immunity? It may be as high as 20%. We don't know how long immunity lasts, but the new strains are throwing a real wrinkle into this. When you look at Michigan, for example, the new strains in Michigan are spreading like wildfire. And we think some of them may be even spreading to some of the vaccinated people. One of our ICU nurse practitioners is out sick right now. She was vaccinated And so there are people, and the vaccine data show is that, you know, the Pfizer vaccine and the Moderna vaccine seem to be pretty effective. Now, they don't have a number on it yet, but pretty effective against the new strains. And nobody that has received a vaccine in any of the trials with any of the vaccines has required hospitalization. Okay, so they're approaching, I think, 60,000 patients now. Not one of them has been hospitalized. That'll change. Somebody who's old and feeble will get it, and even though they're vaccinated, and they'll have to be hospitalized. But it's really, really effective at preventing vaccination. And it's pretty effective at preventing getting it at all. But the wild card is the new strains, so I can't give you a short answer. Giving that answer is frustrating for those of us giving that answer. Yes, sir.
Do you have any idea why a couple of places like India and Brazil have cases that are just spiking, just running off the clock all of a sudden?
I think it's a combination thing. I think it's a tightly packed thing. That's why I think New York City, for example, got it way worse than most other places, is because subways and other things where people are tightly packed. I think lack of access to even masks in India is a concern. I think the Brazilians have their own variant that spreads more rapidly than what we faced. So I think it's a combination of a lot of those factors. The other thing is Brazil's winter is our summer, and so they're going to be off cycle with us some. I'm still not sure how seasonal this thing is, frankly. You know, I was hopeful that once we got through the spring, by the summer it would burn out, as were many people, but it isn't that seasonal, it seems like. Yes, sir.
You said y'all were one of the leading hospitals for trying remdesivir.
Yeah.
How are the results from that?
So it seems to shorten hospitalizations. It may reduce mortality, but it definitely shortens hospitalizations in patients who are sick enough to meet the criteria to get on it, and in patients who come in early enough to get, yes, you meet this checklist of criteria and we'll give you remdesivir. But the patients that aren't eligible are, you know, if I get it today and I get some mild symptoms and I, you know, get tested and I get it and I stay home, and 4 or 5 days from now, then I get sicker and I go to the hospital, I'm not eligible for remdesivir because it's been too long since I contracted it. It's the ones that kind of come into the ER crashing and burning. It's worth giving, but there's a checklist that you have to meet to get it. Yes, sir.
I noticed when you came in, you're elbow bumping everybody. Are you still, like, the mask recommend that versus shaking hands?
Among my family, okay. In a public place where I see myself as somewhat of a public role model, I'm going to stick with the elbow bumping, especially if it's a big group and people I don't know your vaccination status. But on some level, I see myself as being in the public eye and having a role model thing. So I'm going to be more conservative than I might be if I weren't a physician, frankly. And if I see a lot of these same faces here Saturday during the barbecue, I may be a lot more friendly at that time. I feel a little bit like I'm on stage right now. Oh, plenty of supply. At the Alamo Dome, they can't give them away. There are cars coming through there where one person is signed up, they'll give them to everybody else in the car. And you don't even have to have an appointment. And so right now we have supply exceeding demand. It's just a matter of people taking time to get it done. And I think people want it. I know a lot of people that want it. It's just finding the time to get it at this point. You know, the people that are busy and back at work and making up for their lost time when their business was shut down previously, you know, for them to take a half day or whatever to go make an appointment and get it, they're struggling with finding that time and they're trying to make up lost ground.
Speak to the people that are reluctant to get vaccinations.
So let's think about why, and I had this discussion with Reagan earlier. Is it possible that 5 years from now or 10 years from now, we'll find some side effect from this vaccine? I can't tell you with certainty that that's impossible, although that's never happened with any other vaccine in human history. So And that's what some people's reservations are. But I can't tell you with 100% certainty. With regard to the efficacy of the vaccines, you know, the Pfizer and Moderna are more efficacious than the flu vaccine, which most people get. You know, every year you get the flu vaccine if you're over age 50, you know it's only 70% effective. But the Pfizer and Moderna are in the 95 range. The Johnson & Johnson, which is a whole other discussion, but I suspect that'll be the next question if I don't address it. So, but my thought on that is, if that was the only vaccine I could get, I would gladly get it. Okay, right now the complication rate, the serious complication rate is around 1 in a million. I think the risk of COVID exceeds that, and therefore the risk-benefit ratio is in favor of getting it if it's the only vaccine you can get. But I do think the efficacy is better for the Pfizer and Moderna, and I think the safety profile may be a little better for the Pfizer and Moderna. Therefore, if those are available, I'll decline the J&J. And right now, we're not offering those in most of the places in town. We're not offering Johnson & Johnson around San Antonio. But if you do the math, the safety is there for getting the vaccine. The other thing about this disease, and the reason for vaccinating, the reason for masking, okay? It's not about you. Reason for masking, okay? It's not about you. It's about the people around you. Wearing a mask is the same as wearing a seatbelt. It's just a public safety device, okay? The only difference is the mask protects the people around you 3 times as much as it protects you. If you look at the math, okay? Protects the people around you more. So not wearing a mask is like going out and disabling other people's seatbelts. It really is. You're putting your people around you more at risk than yourself if you're not wearing a mask and if you're not getting a vaccine. So but it's about anybody else you come in contact with, the store clerk, okay? The person at the drive-through window at Wendy's, things like that, you're putting them at risk. And so that's why you get a vaccine. That's why you wear a mask. It's partly for you, but the truth is not doing it is like disabling other people's seatbelts. You're taking away safety. And that's not the right thing to do. So that's my speech on why to get a vaccine and why to wear a mask. Yes, sir.
If you're vaccinated, carry the disease and spread it somehow without being sick.
I believe so. You know, the people they've tested, when they say it's, 95% effective, the ones who got it were symptomatic. There are probably some out there that were asymptomatic and carrying it that never got retested because they never had symptoms. So probably.
Problem that occurs. How does that problem occur among people who had no vaccinations at all? Many cases.
Less often than that. I'll put it that way. It does happen, but yeah, less often than that. It happens in people with known risk factors. If you have cardiac arrhythmias, if you have a hole in your heart, things like that. But in patients who don't have risk factors, it's way less frequent and it's 1 in a million in a period of a few months. So when we think of frequency, we think of per patient years, and it's way less frequent than that. So it's rare, but I do think it's vaccine related. Yeah, that's all. Yes, sir.
We know much more than we did 6 months ago about children, 18 and below, 10 and below, 6 and below, in terms of, are they infectious? Is it harmful? Because I'm thinking about schools and the plans for this fall and all of that.
So schools that do some distancing measures seem to be quite safe. Schools that don't, I've seen mixed reports. And to me, that means you can't guarantee safety, but they're probably not as dangerous as if all of us pre-vaccine got together and acted like we were school children, because the children do seem to do better with it and spread it somewhat less, which it makes sense that they do better with it. It doesn't make sense to me why they would spread it less, but they seem to. And so that's a question mark in my mind still. Yes, sir.
One of my daughters has the J&J vaccine. Any way to increase that 70% or what have you?
Not currently. People have suggested that that might be a group to revaccinate in the fall. If J&J wants to do studies, but right now there's no studies to support that. But I think where we may be heading is an annual fall combined COVID flu vaccine. You know, for the most recent COVID strains, the most recent flu strains, everybody gets it in August or September, and then we're all vaccinated for that year. We do it. It might be something that we're all headed to down the road.
Thank you.
Yeah, Tim.
Huge increase of patients, plus you have a higher locum doctors, nurses, so huge increase in cost of the hospital. Did they get any federal funds to help with that?
I believe so. Yeah, I believe there are funds for COVID patients in particular. Yes.
But the hospital capacity was way down several months ago. How close were we to triage? The hospitals had to decide who lives and who dies.
So we have been pretty fortunate here in San Antonio. We never reached that level. I did see some news reports from Methodist. There were some reports of deciding who got ECMO and who didn't. That was the one limitation. So going on extracorporeal membrane oxygenation, where we run your blood through a machine to get oxygen in it and back into you, there's only a certain number of ECMO machines and ECMO techs in San Antonio. There were, through the two surges, and I believe it was mostly Methodist, and Mr. John, feel free to correct me, but my guess is somewhere between 5 and 20 patients that we would have liked to have put on ECMO that we didn't have capacity for. Is that a fair statement?
We only have 8 ECMO machines.
Yeah, and we have 2. And so there were a few patients but I can't say that's 100% black, white, live and die scenario, because if you're sick enough to go on ECMO, your mortality is going to be very high. So it's not, going on ECMO is not a guarantee of survival, but it was just, you're going to die now rather than you're going to get a chance on ECMO and see if you're one of the 25% or so that survive. In terms of declining, refusing patients and declining access to beds and access to other things, there were no other limitations except ECMO machines. We did stop, for example, in both surges, we had to cut down operating room capacity at University Hospital quite a bit, because the big cases that then require you to be admitted for a few days after surgery, we're going to have to go to beds we didn't have. So we shut down any patient that needed to be admitted couldn't get surgery. We only did outpatient surgery for a while, so there were limitations there. But if it was urgent, we did it. But for elective things, to take care of your colon cancer or your breast cancer, things like that, didn't get done for a while. Yes, Tim.
With university receiving transfers from, I think it was 21 other counties, on average, what percentage of patients are from outside their county?
So that's not just university, that's all of us in San Antonio receiving transfers. We're a region, we work together, okay? Now, if it's a trauma patient, there's only 2 hospitals they can go to, right? There's us and there's Brook Army Medical Center. With that, we get 75% of the transfers from outside the county, BAMC gets 25%. But in terms of the COVID patients, University actually did not do as big a load as Methodist. Methodist did a large load. Baptist did a large load, particularly the El Paso transfers. There are Baptist facilities in El Paso that transferred within their system to San Antonio. So most of the El Paso transfers went to Baptist. So there wasn't, University Hospital didn't get a disproportionate load. In fact, I think Methodist actually had more COVID patients than we did throughout their system. Is that correct?
Yeah, we maxed out about 585
Just COVID.
on one day.
Yeah. So Methodist did and then again, the regional sharing. We kept open to our trauma mission, okay? Because as much as Methodist doesn't want more COVID ICU patients, they sure as hell don't want a trauma patient in Methodist Hospital, because getting the face surgeons and the orthopedic surgeons and the neurosurgeons to all play well at 2 o'clock in the morning to do trauma care when they're used to their daytime elective practices is a real challenge. Whereas we do that every day. And so the one thing we figured out is if we can keep our trauma mission going, the other hospitals around town will help support other missions. So, yeah. All right. Thank you very much.
Dr. Dent, thank you so much. And Becky Holmes secured our speaker today, so thank you, Becky, but she went out. She's got a blood appointment out there. Anybody wants to get blood, please do it today. Dr. Dent, thank you so much. Appreciation from the Aggie Club. We've got compliments of Olmer Fiesta Spices, Aggie owned and operated. We'd like to present you today.
Awesome.
And I'll give you a chicken wing. All right. I'll get right there.
Soupy's joining us today. You haven't been here in a while.
Soupy!
Today's his 99th birthday.
99, okay. We've got to sing you happy birthday, Soupy. A 1 and a 2 and a 3. Happy birthday to you. Happy birthday to you. Happy birthday, dear Soupy. Happy birthday to you. Hey, let's go, Soupy. All right, we'll see you next year, same time. All right, welcome. Thank everybody, Gig, and we'll see you next week. Thank you.